Presenting on behalf of Medicine 3. President Mr. X is a 28-year-old housewife from Karur. She is primary at 19 weeks of gestation, with prior cycles were regular, and she's presented with 3-year history of intermittent fatigue. Outside evaluation, she has noted to be of anemia for the past 3 years, for which she received multiple transfusions and platelets also prior to the pregnancy. She's been following up booked outside, and she's following up in the Karur GH. They've done some evaluation where the bone marrow is showing some hypocellular marrow with reduced megakaryocytes. She received therapy there, and further they came here for further management. There was no history of fever, no loss of weight, loss of appetite, no history is 28-year-old primary with prior comorbidities of hypothyroidism and seizure disorder, present with symptomatic anemia and probable thrombocytopenia depending upon the prior transfusions. So evaluation here, we consider the approach for the biocytopenia. Her problems started even before the pregnancy. So bone marrow, either production or destruction or sequestration issues. So bone marrow, failure, infiltration, infections, destruction from autoimmune or inflammatory pathologies. Specific to pregnancy in her, HELLP syndrome also can be considered, but since it started prior to the pregnancy. So evaluation, she was anemic, HB was 7.9, MC of 91, and retics for 2.05. The production index was 0.7. It was hyperproliferative. Platelets were 34,000 at presentation. Total counts were 3,700 with neutrophils of 44%. Blood picture was leukopenic. There were no blasts, no cystocytes. LFT, there were no elevation in the liver enzymes, no hyperbilirubinemia. Renal functions were normal, electrolytes were normal, tumor lysis were with normal limits. Disease activity wise, we've done LDH, which is normal. For instance, in the pregnancy with some cytopenia, we for HELLP and hypertension evaluation, urine protein creatinine was normal, not elevated. Etiology evaluation, blood-borne virus screen was negative. B12 levels and folate were normal. Ferritin was elevated. Autoimmune ANA, C3, C4, DNA was normal. Ultrasound did not show organomegaly or nodes. Chest X-ray was not done in view of the pregnancy. Clinically, she didn't have any lymph nodes. Proceeding further for the bone marrow aspirate is showing a cellular marrow with this erythropoiesis and this megakaryopoiesis. Trifine is showing a markedly hypercellular marrow. So here's a lady with pregnant lady with a prior probable diagnosis of a myelodysplastic syndrome. Further cytogenetics and molecular markers still awaited on. So just a short view on pregnancy association with MDS. A person with MDS developing pregnancy. So MDS is main features are there's ineffective erythropoiesis and associated with cytological molecular abnormalities, and they have high risk for there are certain characteristics for transformation into a full-blown leukemia. So this is just an update. This is the latest edition of WHO, which classified further MDS into based on the cytogenetics and genomics modification. Not just on the prior morphological classification, which involved just the blast and excess blast. So what is the outcome when compared in patients with MDS when they're pregnant? This is an article from 2015, which they have compared 25 pregnant women with prior or during the pregnancy diagnosed of MDS. And control group was out of these 25 people who did not have any complications at the end of the pregnancy. Outcomes were pregnancy and neonatal outcomes. This is over almost 25 years they've searched for this pregnant women. So what is the outcome group? They looked at whether there was intrauterine fetal death, or there was ending up in a premature delivery, or there's a low birth weight, the patient had a PPH, or the postmortem complications resulting in severe infections or heart failure or a bleeding in the brain. Control group was any of these without people without these complications. So the outcomes they measured. So if the WBCs were decreased in the MDS, we're expecting a reduced WBC, out of which 23 people, 15 had out of the 15, it was almost similar numbers who had the same outcome, whether they didn't have the complications or with complications. Anemia, severe anemia is significant in this study, where out of the 23, 11 people had severe. Severe is less than 7. Out of them, 9 out of 11 had the serious complications. We have one of these complications were considered. Platelet count was less than 20,000 was considered as severe. 20 people have, out of the 23, 20 people had severe this thing, but however, 20 of them fall into the, half of them had complications, half of them didn't, so it was not significant. Having a gestational hypertension as another complication in these people resulted in a significant proportion of people having a poor outcome. So how do we approach this patient? Once we have a diagnosis, next thing is to risk stratify them. So that will help us in deciding on how to treat and what to treat them with. And the stratification is based on the older, prior, same revised international prognostic scoring systems. This is based on what are the cytopenias, the thrombocytopenia, leukopenia, and anemia, and the percentage of blasts in the marrow, and what are the cytological abnormalities. The newer IPSS-M also involves the genomic genetic data, also including it with the stratification. So our IPSS, it involves, depending on the, like we discussed, it's based on the blasts, the cytopenias, and the cytogenetic abnormalities. If the points, it's either based on the points, it's very low, the 5 groups of risk stratification. So this is another just in outcome assessment based on the cytogenetics. So if you go from, if they have single genetic cytogenetic abnormality, their survival is around 60 months median. Whereas the more the number of mutations, the survival has been coming down gradually to 5 months overall. So based on the risk stratification, based on this stratification, if it's very low or low, it's considered as a low risk MDS, which in a pregnant woman can be allowed to go through the pregnancy safely with supportive management. If they are considered in the high or the very high risk population, they need to have immediate therapy. So for which chemotherapy or other therapy cannot be given during a pregnancy. So which they need termination of pregnancy. So immunosuppressive therapy, chemotherapy, and stem cells are not during the gestational period, and definitely not in the first trimester. And supportive care involves making sure the hemoglobin target has to be more than 7. Platelet count, in general, there's no consensus, but overall, it's advised to maintain about 20,000 to prevent fetal-maternal hemorrhage during pregnancy time. And if the patient is going through a vaginal delivery, need to maintain a cutoff of more than 20,000, and for cesarean, needs to be maintained more than 50,000. So once this is a common algorithm for all patients, nothing specific for pregnancy. But once we identify whether they'll have to be terminated or they go out with the pregnancy, then they should be either given one of these based on the same risk stratification. Under age, whether they'll get either lenalidomide, which is the commonest thing to give in the low risk population, or they'll get intensive chemotherapy followed by a stem cell transplant, depending upon the age characteristics. So low risk MDS can be allowed to complete pregnancy, whereas high risk needs termination.
Did you name it doctor?
I just saw a newspaper where there's a pregnant fighter pilot who went in the Sonic flights. She was, a pregnant lady with sick conditions.
Any other comments or questions from the audience? Waiting for the cytogenetics to come.
Yes.
And then it's
The stratification.
So, what are the main criteria for high risk?
So high risk is depending upon whether there are more the blast cells in the marrow. If it's more than 10%, they'll be considered given a 3 points, which itself will take them to an intermediate risk.
Someone who would require treatment.
Yes, immediate treatment rather than going through the pregnancy and awaiting. Then presence of other cytogenetic abnormalities with a deletion of arms of chromosomes 5q, 12q, and other chromosomes, and inversions of 3 also. Depending upon the number of these things, if there are more the number of deletions, more the high risk nature.
So your main reason for treatment will be basically the presence and the percentage of blast rate.
Yes.
Something that you cannot give during pregnancy. All other things you can support during pregnancy in terms of any of the blood products. So any reason when you may not want to continue pregnancy would be is when a person needs treatment, which will be mainly blast cells. Does your treatment is dependent on the cytogenetics in terms of?
It just so the more the number of cytogenetic abnormalities, they're usually taken for transplant after the chemotherapy. That's another reason for additionally for transplant indication. Because even after reducing the burden of the disease, they still have the same abnormalities. So you might.
Just the more the cytogenetic abnormalities, the higher risk of AML transformation. So it becomes an AML, then the treatment completely changes and the prognosis completely changes. You know, but does that at the earliest?
You had a slide on this. I think the next
So
slide
technically,
is.
till the blast is not there, you may not just give some
Once the blast comes, it has
Yeah.
already gone into AML transformation, so the management completely changes. So
So-
it's better to treat it before it becomes a AML rather than after.
So treating on basis of cytogenetics to prevent the blast transformation.
The prognosis, the management completely changes once there are blasts. It's become either NBS with excess blast or the AML transformation. The management is much more easier when it is at the NBS phase rather than